welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy way. And today's video is a continuation of the Express Revision course for periodontics. So before we get started, make sure you subscribe to the channel and click on the bell icon so that you don't miss any of our future notifications and you don't have to take down notes now. There will be a link provided in the description box below, and also you can find more interesting notes on our website www.x2.com, and you don't have to load up your phone memory with the notes. They are available online all the time. So guys, talking about the today's topic, which is a periodontal ligament. So periodontal ligament, there are another names for the periodontal ligament such as desmodont. So desmodont was actually a bat sucking blood. Also it can be also known as the gomphosis. Gomphosis is a word which we use for the pagan socket joint. Like as we know that the tooth is embedded into the socket, right? So for the pagan socket joint. So as the tooth is anchored into the socket, so therefore we use this term gomphosis. And also the periodontal ligament is also known as the alveodental ligament, because it is a ligament surrounding the tooth, right? So it is basically a fibrous connective tissue. That is why we call the term ligament to use the term periodontal ligament, because it is a fibrous connective tissue. Also we use the term dental periosteum for the periodontal ligament. Guys, you will have to excuse me today for the noise in the background, if at all you can hear this, because I waited for a long time to record the session, to record the class, but still I cannot wait for any more longer. So talking about the periodontal, also we call it the periodontal ligament. So this periodontal ligament surrounds the tooth, surrounds the root, we must say. It surrounds the root and it is connected to the inner wall of the bone. So if you see in a periodontal ligament, guys, we have got surrounding the tooth, and if you can see here, guys, it is between the bone and the tooth. So this is a ligament between the bone and the tooth. So this part, in the yellow we have the bone. The black one is for tooth. So in between, if you can see, this purple color is our periodontal ligament. So this is the bone. Then the tooth. So in between the tooth and the bone, the fibrous part, the fibrous connective tissue is our periodontal ligament. And if we talk about the width of the periodontal ligament, which is more often asked questions, so that is the average width of the periodontal ligament. So it is actually not uniform. It varies from age to age. Now, first, second decade of life, it is 0.21 millimeter. And fifth, sixth decade of life, it diminishes in size and it becomes in the width, and it becomes 0.15 millimeter. So if we talk about the average width of the PDL, then it is 0.20 millimeter, guys, which is the average width of the periodontal ligament, which you must remember always. And with the age, we see that there is, if we talk about width, guys, then it increases with the age, and the thickness. So with the increase in the age, with the increase in the age, the thickness decreases. So width decreases with increase in the age. So aging, I can write aging also. And we see that increase in the width of the PDL, there is a widening of PDL which is associated with certain pathology like trauma from occlusion, like scleroderma, where there is a thickening of the skin. So skin becomes very hard in case of scleroderma, because there is a, derma means skin, sclero means hardening of the connective tissue. So what happens in scleroderma? There is hardening of connective tissue of the skin and the skin, right? So then osteosarcoma, also we see that there is increase in the width of the periodontal ligament. So these all are the increase. Also we see in the osteosarcoma. And where all situations we don't see PDL, so there is absent PDL, right? in case of starting from the A itself, ankylosis. So what happens in ankylosis is there is fusion of tooth to the bone. Directly the cementum is attached to the bone. So ankylosis, which is most frequently it occur in the deciduous teeth as compared to the permanent teeth. Right, so I must write primary here, otherwise you will get confused. So ankylosis is fusion of bone and the cementum. We know that PDL is derived from the dental sac or the dental follicle, and the organic matrix get mineralized by the cementoblast. So cementoblast are the cells which forms the cementum. And if we talk about the composition, guys, of the PDL, we have got two components. One is the cellular, another one is the extracellular components. Cellular and extracellular. Cellular component will be talking about the cells, right? We know that. So cells in the PDL are fibroblast, osteoblast, also we see osteoclast, which are associated with the desorption of the bone, cementoblast, which are associated with the formation of the cementum. Blast word means forming cell, clast means cutting cell. C for clast, C for cutting, you can remember. So if cementoblast are there, that means they form the cementum. If osteoblast are there, that means they form the bone. And also we see the epithelial cell rest of Malleus. So these are the remnant of Hertwig epithelial root sheath. Along with that, we see some undifferentiated mesenchymal cells. So mesenchymal cells which are undifferentiated, and we know that mesenchymal cells can transform into any kind of cells, right? Mesenchymal cells. Also we see mast cells, macrophages. So all these cells. Macrophages. Now, in the extracellular component, sometimes we have to challenge our situations. Like there is I think marriage going on, so almost whole of the day I was waiting for it to get stopped, all this music, so that I can take a class, but still life goes on like that. So talking about the extracellular component, guys, extracellular means there are no cells which we are talking right now. That means most of this is water, which is 70%. Then we have got the fiber component also. So fibers, we know that most of the fibers are the collagen fibers, right? And the ground substance, of course. In the ground substance, we have proteoglycans. So proteoglycans, and then we also have glycosamine glycans, then glycoproteins, then polysaccharides, right? So talking about the fibers, main fibers we have are the principal fiber, we can say. See, the principal fibers of the periodontal ligament, always remember that the principal fibers of the periodontal ligament are the collagen, are made up of collagen. So the principal fiber are made up of collagen. Remember that the principal fibers are made up of collagen. So collagen is also made up of different proteins like glycine, proline, hydroxylysine, hydroxyproline, and if we want to determine the amount of collagen in the tissue, then we determine it by using the hydroxyproline content in that tissue. So the principal fibers, I'm going back to the point again, are made up of mainly collagen, which is the type 1 collagen, right? We have talked about while studying about the collagens, the type 1 collagen, or remember in the last video, in the first part of the video, we have talked about that all means type 1 collagen is mainly present in all the tissues. So reticular fibers are composed of type 3 collagen fiber. Then type 4 collagen fiber is associated with the basal lamina, the basement membrane, and type 12 collagen fiber is associated with the development of the tooth. So organization, alignment of the periodontal fibers during the tooth development is associated with the 12. So guys, in the fibers, we have got immature fibers also. We'll be talking about three kind of fiber. One collagen, which is the principal fiber. Another one is the immature fiber. Immature fiber. And then one more kind of fiber we'll be talking about, that is the indifferent fiber plexus. Indifferent fiber plexus. So this indifferent fiber plexus, the fibers of this run in all the direction and they form a plexus. Plexus means guchha. So plexus means network. So network of you see fibers in all the direction, that is the indifferent fiber plexus. Talking about the immature fiber, guys, we have two kind of immature fiber. One is the illunin, and another one is the reticulin fibers. So illunin fibers are a kind of elastic fibers. They are formed by the elastin as well as oxytocin fibers. So they are elastin plus oxytocin fibers. They forms the blood vessel lining. They connect to the bone and the blood vessels. These are the illunin. Talking about reticulin fibers, they are made up of type 3 collagen. So type 3 collagen basically help with the basement membrane formation. Type 3 collagen. So these are the immature fibers. Elastic fibers are absent in the PDL. They are present in the blood vessel. They form the elasticity resiliency, right? So we know that elastic fiber are absent. Instead of that, we have got the principal fiber as the collagen fibers and some immature fibers like illunin fibers, reticulin fibers, and we also have the indifferent fiber plexus. And guys, also we have got the cellular component, the cells like fibroblast. Fibroblast help in the formation of the collagen. So here I am making an arrow that fibroblast forms the collagen. Fibroblast of the PDL, they help in forming the principal fibers of the periodontal ligament. See, the principal fibers of the periodontal ligament are made up of fibroblast, and also the elongation or continuation of the principal fibers when they are going into extremities, we will be talking about it, then we call them Sharpie's fibers. So guys, they are present, Sharpie's fiber are present in the cementoblast, but they are actually the fibers of periodontal ligament. And also we have got cementoblast and osteoblast. Osteoblast form the bone, osteoclast cut the bone. Cementoblast form the cementum, cementoclast cut the cementum. But the difference between osteoclast and cementoclast is that also we see osteoclast in the remodeling process. So if you have studied, if you have watched any of my videos, I've talked about couple of times that osteoclast and osteoblast both are associated with the remodeling. Remodeling doesn't mean that there is only bone which is forming. Suppose this is a portion of a bone, guys, and if the bone formation happens, it doesn't form like this, that bone is just adding. So if addition of bone is here, so there will be that means deposition of bone is there, that means the resorption will also occur. So there will be osteoclast which are present at the site and osteoblast also which are present at the site. So in the remodeling process, that means the normal physiologic process of the bone, the normal physiological resorption of the bone, we see osteoclast. While on the other hand, if we talk about cementoclast, they are only seen during the pathology. So pathological resorption only we see cementoclast. So this is the difference between osteoclast and cementoclast. If osteoclast are present, that doesn't mean that there is going to be pathology. And if cementoclast are present, that means we see only the pathology, because we see in case of the pathologic resorption only the cementoclast cells. right? And the extracellular components, sometimes I keep on repeating the things so that you don't have to memorize. By the end of the lecture you already remember most of the things. So that is the reason sometimes I keep on repeating the same things. So the types of collagen we have already talked about in the previous video, that all halls a base may, that is what we have, the mnemonic from which we have remembered it. All means all, that means the type 1 collagen fibers, if you remember. Let's just write it once again. So all, because this is so important, all holds a base may, right? Ab base may. So this is what we have remembered, that all means type 1 collagen fiber which is present in almost all of the tissues. Hall, that means hyaline cartilage. The type 2, that means type 2 is present in the cartilages. And then type 3 we have talked about is arterial vessels. Then we have talked about type 4 in the basement membrane, right? Type 5 in the cell membrane. Type 6 in the ligament and the bone. Then type 9 in the cartilages. Type 10 and 11 again in the bone and cartilages. So all of these are the types of the collagen fibers. Now guys, talking about the principal fibers of the collagen. So we have got the principal fibers which are made up of the collagen, we know that. So we will be talking about the principal fibers, guys. Here, the principal fibers of the periodontal ligament, which is very important. So we'll be talking about the first one we have is the transseptal fibers. Transseptal fibers. Now, as the name suggests, that transseptal are going to be present between the septum of the bone, between the interdental bone. So these are present, these can be reconstructed even after the destruction of the bone. So these are present with the interdental bone, you can say. So these can be rebuilt after the bone destruction, and these fibers are considered as the belonging of the gingiva because they do not have any bone attachment. Second one, guys, we have are the alveolar crystal fibers. Alveolar crystal fibers. So we are going to write again the important points of it. So can be reconstructed. And talking about the alveolar crystal fibers, guys, so they prevent the extrusion of the teeth and they resist the lateral movement. So because they are involved with the crest of the bone, alveolar crest, as its name suggests, the alveolar crest, that means crest of the bone. So they prevent the extrusion of the teeth and they resist the lateral movement. Now let's draw the alveolar crystal fibers. Here we have at the crest of the bone. So towards the crest of the bone, I could have done it this way. One second, guys. Let's just make the PDL. I am making a wide PDL. Okay, this is just a diagrammatic representation. So this is the PDL, right? So the alveolar crystal fibers, if you see, they are present at the crest. So guys, these are our alveolar crystal fibers. Alveolar crystal fibers. On the both the side they will be present. Now the second one we have are the horizontal fibers. Third one, the horizontal fibers. So they extend right angle to the tooth. If you see the long axis of the tooth, they are just right angle to the long axis of the tooth. So I'm just gonna draw it here, guys. like this. These are the horizontal. If you can see here, they lie perpendicular to the long axis of the tooth. So these are the horizontal group of fibers. From cementum to the bone. Third one, guys, we have are the oblique fibers. Oblique fibers. Now, oblique fibers are the largest group of fibers, are the largest principal fibers of the periodontal ligament. This can be even asked as a question that which are the largest fibers of the PDL. So, the largest group of fibers are the oblique fiber, and you can also remember O for oblique and O for occlusal. So, occlusal. So, they control the masticatory forces. They help in controlling the masticatory loads. So you can remember O for oblique and O for occlusion. So the oblique fibers are present obliquely, and if you see from the cementum, guys, they are down, and the bone, they are coming up like this. So these are the oblique fibers, like that. Cementum down and again bone up. So these are oblique fibers. Next one, guys, we have are the apical fibers. So because as the name suggests, they are going to be present in the apical region of the root, that means the root apices, and you can remember A for apical and A for absent in incompletely formed root, absent in incomplete formed root. Because we know that they are present in the root, and if root is not there, that means these fibers are not there, which is quite an obvious point, right? So these apical fibers are present in the apical region. They prevent with the tipping movement. So these are the apical fibers, guys, which are present at the root apex. Right. So the apical fibers. Prevent the tipping movement. And the last group of fibers we have the last group of fiber, guys, are the interdental fibers. Interradicular fibers. The sixth fibers are the interradicular fibers. As the name suggests, they will be present in the furcation area. Radicular fibers. So they are going to be present in the furcation area of the multi-rooted tooth. You will find these in the multi-rooted tooth. So these are the interradicular fibers. So we have covered 6 type of fiber. The transseptal fibers, then the alveolar crestal fibers, then we have studied the horizontal, oblique, which is present in the majority of the groups. So starting with the first one, transseptal fiber, they can be reconstructed even after the bone destruction, and because they do not have any bony attachment, that is why we have not shown it, like they will be present here like that. So there is no boniest attachment, so therefore they can be reconstructed because there is no bone attached to it. Then we have studied the alveolar crestal fiber. If you can see one here in the purple, we have got the alveolar, this one are the alveolar crestal fibers which are present at the crest of the alveolar crest. So they prevent the extrusion of the tooth, so they prevent the tooth going out right from the socket because they are holding it from the top, so they are not letting it out, and also they resist the lateral movement because they are present on both the sides. Then we have got the horizontal fibers which are present perpendicular to the long axis of the tooth. If you can see here, this is the long axis of the tooth, they are present perpendicular to it. And we have studied the oblique fibers. Guys, oblique fibers are going from the cementum and going up above occlusally. So you can also remember that occlusally they are going up above like this. So these are the oblique fibers, and also O for you remember occlusal, that they prevent the heavy masticatory loads. So they take up, they resist, they control the vertical masticatory loads or the forces. Then we have got the apical fibers which are present at the apices of the root, and if roots are not there, definitely these fibers are going to be absent in the incompletely formed roots. So they prevent the tipping. Then we have got the guys the interradicular fibers. So these are the interradicular fibers which are present at the furcation area of a multi-rooted tooth. So they fan out from the cementum into the furcation area of the root. So guys, these are the 6 types which we have studied, and one more thing we would want to study is that, see, suppose this is the purple color one is the PDL, and in the PDL we have got the collagen fibers, right? So suppose these are the collagen fibers, so made up of type 1 collagen fibers. So some of the collagen fibers, they extend into the cementum. So some of the collagen fiber, they extend into the cementum, and the one which extend into the cementum we call the Sharpie's fibers. So here the term Sharpie's fibers. These are actually the fibers of the PDL. These are the fibers of the PDL, but they get into the cementum. Into the cementum. So guys, talking about the function of the periodontal ligament, PDL, important thing till now which we have covered is the thickness of the periodontal ligament, the fibers of the periodontal ligament, talking about the functions of the periodontal ligament. So functions of the periodontal ligament is, the major function is it takes up the masticatory load, the occlusal forces. So because if the heavy forces, suppose if this is a teeth, if heavy forces are coming, we do not want that these forces are transferred to the bone, right? We do not want this to happen, because if this happens, what is going to happen is there is going to be resorption of the bone due to the heavy occlusal forces. We have studied the natural teeth take up so much of pressure. It can even take up to 50 kgs of pressure, right? So if it is taking this much of pressure, then it is going to put this pressure on the bone. But what happens when if there is so much of pressure which is putting on the bone, then there is going to be resorption of the bone. We do not want this happen. So here comes the role of the PDL here. He is our saver. So PDL is the saver of the tooth. So it is going to take up all of the masticatory forces, and it is not letting the forces coming to the bone. So in that way, the PDL act as the shock absorber. The shock absorber, right? The rising star. So the shock absorber. So there is a transmission of occlusal forces to the bone, which is, let's talk about the functions of the PDL here. So first of all, there are physical functions, there are formative functions, formative and remodeling. So the physical function is that it takes up the load, or I can just write the shock absorber, right? Shock absorber. That means it is taking up all the occlusal forces, masticatory forces, and it is absorbing it, all the forces. So like that we have the shock absorption. We have got two theories One is the tension theory. So according to tension theory, it states that the fibers of the periodontal ligament, they support the tooth, they transmit these forces to the bone. And the another one is the viscoelastic theory. So it states that the occlusal, the displacement of the tooth is controlled by the fluid movement, not the fibers. So fibers play the secondary role here, they are not the primary role. So according to viscoelastic theory, it says that, as the name suggests, visco means anything fluid. So it says that the fluid, the tooth movement, the displacement of the tooth is largely controlled by the fluid movements. Then coming to the another function of the PDL, which is the formative and the remodeling. So when we have studied the components, if you can see here, we have studied the cellular and the extracellular component. In that we have studied fibroblast, osteoblast, osteoclast. So the periodontal ligament constantly undergoes remodeling. If you can see here, we have got blast also, clast also, and we have talked about that. There is a resorption process, formation and the resorption, which we call the remodeling. So remodeling is not, I have talked about couple of times that remodeling is a combination of the deposition as well as resorption. So remodeling means the addition is also there, the formation is also there, resorption is also there, the fibroblast forms the collagen, and also there are mesenchymal cells. You remember I told you undifferentiated mesenchymal cells which also develop into osteoblast, cementoblast. Therefore there is a formation process which is happening, and also the rate of collagen synthesis in the PDL is very fast. So the collagen formation, I must write, the collagen synthesis in the PDL is fast, at least twice fast as gingiva, and 4 times faster than the skin. So it is very fast. And one more thing I would like to tell you is that if there is increase in the function of the tooth, so or I can say just the hyperfunction, right? If there is hyperfunctioning of the teeth, then the PDL, there is a widening of the PDL we see. And if there is hypofunction, decrease in the function, I should have written the hypofunction. So if there is hypofunction, that means we are not using tooth much for mastication. In that case, there is a decrease in the PDL. So also there are some age related changes. So with age we see, let's write in here itself because this is the last point most probably. With age, with increase in the aging, we see that the elastic fibers are increased, elastic fibers of the PDL, and decrease in the fibroblast or the collagen fibers. And we know that these principal fibers of the collagen are made up of collagen, and since they are made up of collagen, there is decrease in the collagen. That means there is going to be, with age, decrease in the width of the periodontal ligament. And initially the first point which I told you in the PDL is that initially first second decade it is 0.21 millimeter, but as a person progresses towards aging, this widening of the PDL, it decreases by 0.15 millimeter, and if we take the average value, then it is 0.20 millimeters. So that means with aging there is decrease in the width of the, or decrease in the periodontal ligament. Now talking about the cementum. So the next topic we have, guys, is the cementum. So guys, this is here the structure of the tooth. We have got the crown, the root, then we have the pulp inside, right? So we have the pulp inside, which contains the nerves and vessels, and then we have outside this dentine. So we have got dentine outside it. So the dentine, then we have the enamel. So then we have the enamel outside the dentine. And if we are talking about the root, then we have outside the dentine, we have a layer of cementum. So this is the layer of a cementum. Now cementum is also kind of a light yellow in color, and outside the cementum we have got the period, which we have just now covered, and outside the period we have got the bone. So this is the period. So this is the structure of a tooth which we already know. So the cementum, which is avascular mesenchymal tissue which covers the root, and when it is fully mineralized, it hardens, it gets calcified, but still less than the dentine, of course. So it is light yellow, and again lighter than the dentine. It is the color shade is lighter than the dentine. So if we talk about the thickness of the cementum, so it is thicker at the apex, that is, it is thicker here at the apex and thinner in the coronal part. So thinner at the CEJ. And guys, if we compare the cementum with the PDL, so PDL is more like an hourglass shape. So it is thinner at the central part of the root. So which is the hourglass shape. So if you see the cementum in the coronal half of the root, you will find it is 15 to 50 or 16 to 60 to be exact, 16 to 60 micrometer. And we know that the cementum is thicker at the apical region, apical third of the root, also in the furcation areas, which is somewhere close to 150 to 200 micrometers. So guys, this part of lecture we will not be covering the histology of the cementum. We'll be just talking about the hiding points. So talking about the classification of the cementum. You will find that there is a acellular cementum, then there is a cellular cementum. Acellular, what do we mean by the term acellular? Means that the absence of the cells, right? So acellular means absent, cells are absent. So what is there in that part of the cementum is usually the fibers. So this acellular cementum, we also call it the primary cementum. So if you look at the acellular cementum, it is present in the cervical. So cervical third of the root. Then the cellular cementum is the secondary cementum. So as the name suggests, there are cells which are present in this cementum. So it is present at the middle, or we can say the apical third of the root. Then guys, there are two kind of fibers also. So fibers are one fibers which are from the cementum itself. So these are called the intrinsic fibers. So because they intrinsic means from inside, so they are produced inside the cementum. And the another one are extrinsic fibers, and we have talked about in the periodontal ligament that the fibers of the periodontal ligament are actually the principal fibers, which are the collagen fibers, but some fibers of the principal fiber, they get terminated into the cementum. So these fibers are what do we call the Sharpie's fiber in extrinsic fibers. So these intrinsic fibers, they are smaller and they run parallel to the surface. So they run parallel to the surface of the cementum like this. And the extrinsic fibers, because they are coming from the PDL, so we have to draw the PDL also, guys. So this is the, now this is the PDL we have got outside the cementum, right? So the PDL, some fibers are coming from the PDL and getting embedded into the cementum. So these fibers are what do we call the Sharpie's fibers. So if you can see here, the fibers are coming into the cementum. These are the fibers of the PDL. So fibers of the PDL. Because since these are not internal fibers, they are coming from the external source, so what we call them extrinsic fibers. So these are larger group of fiber, and if you see, these are perpendicular to the surface of the cementum. So these are the Sharpies fibers. Sharpies fibers, which run perpendicular to the surface of cementum, and they are present in the majority of the cementum. So guys, based on that, Schroeder gave a classification for the cementum. So based on that, we have got different type of fibers. So the first one is the acellular, afibrillar cementum. That means the cells are absent because there is no cell. Acellular means cells won't be present, and fibers also won't be present. If you can see here, afibrillar, that means fibers are also missing out here. So second one is the acellular extrinsic fibrillar. So that means cells are absent and the fibers are the external fibers, and we know that external fibers are the Sharpies fiber, which are coming from the PDL. Extrinsic fibrillar, right? Then we have got the cellular here. Now we'll be talking about the cells. So the cellular, one second guys, the cellular mixed stratified cementum fibers. So these are the cellular mixed stratified cementum fibers. Then we have got the cellular intrinsic fibrillar. Now the cells are present and the intrinsic fibers of the cementum are also present. So these are the cellular intrinsic fibrillar. That means the fibers are from the cementum itself. Then we have got the intermediate cementum. Intermediate cementum, which is also known as the layer of Hopewell-Smith. So guys, if you remember in the lecture of the cementum, we have talked about a story. How do we remember that, where all these fibers are present? So remember, we have to go back in our childhood. Every one of us must have a story that if the parents' anniversary is coming, or if the siblings' birthday is coming, we used to save some money to buy the gift for our siblings or our parents, like that. So we have a piggy bank. So in the piggy bank, we used to store the money. So first of all, when we used to plan give a present, right? Plan to give a gift on the anniversary or on the birthdays. So what we used to do, whatever money we used to have, we used to put first. So the cells, we can remember it from the coins, so the chiller, and the notes we can remember it from the fibers, right? So because these are like this, if we see in the piggy bank, they will appear like this. So let's make separate colors for both of them. So for cells, let's take the red color, and for fibers, let's take the purple color. Okay. So first of all, the story starts as whatever money we used to have, we used to keep it. That means the notes also and the chiller also, right? So we used to put, first of all, whatever money we used to have, we used to keep it like that, right? So this piggy bank is more like our tooth. We have to take it like a tooth. So then whatever money, whatever chiller we used to save, we had to keep it, right? So first of all, we used to have some amount of money before buying the gift. We used to have some money. So the money, that means the big one goes beneath, right? So the big one goes beneath. Then we only leave with the chillers. So then the mixed one here. So this is all the money we had, and then we start saving money for a month or so, maybe for a few weeks. Then we start saving money. Once we start saving money, we have only few chiller, we can say, left. Then some occasion comes, for example, in India we have got so many of festivals, in that we used to get money. I used to get money in most of the festivals. So most of the festivals, or any relative come, they used to give me some good money, right? So again the note goes up at the top, and once I had good amount of money, that means I'm ready to buy the gift or buy the present. So we are going to take like this tooth, the structure of tooth the same way. That is, this is the structure of tooth. Let's draw it. So in the apical region, if you see, we have mostly like the money which I had myself. So these are the intrinsic money which I had, right? So intrinsic. And if you see here, which is mostly kind of cellular intrinsic, right? Then guys, there is a mixed one. That means the chiller is also there. That means the coins are also there, and the notes are also there. And on the top of that, I had a money which I got it from the relatives, from the outside. So that is the extrinsic. And rest of my piggy bank is empty. So that is no notes, no coins. So that is acellular and afibrillar. Afibrillar. So you can remember it from your own experiences, from your own story, that coronal part. So this is the coronal part. The coronal part, acellular, afibrillar, that is no money, no coin. Then we have got the money which we got from the external source, that is from relatives or something. So the coronal half we can say, or middle half also you can put it that way. That is our extrinsic fibrillar, right? Then we have in the apical region, guys, that is the bottom of our piggy bank, we have got the mixed one. Mixed and intrinsic, whatever money I had, intrinsic, right? So this is how you can remember all these fibers, that in the apical region there are mixed fibers, there are also cellular intrinsic fibers, and as you go from the apical region to the top of the tooth to the cervical region, so then we have got external fibrillar, and on the top there is no cell, the piggy bank is empty, so no cell, no fiber, so that is the acellular, afibrillar. So you can remember it that way. Now going back to the point again, acellular, afibrillar is in the coronal part, and then mostly at the CJ, we can write at the CJ. Then we have got the extrinsic, right? Then we got the extrinsic, that is the money from the relatives. So that is the, or on the festivals, that means from the outside source. So in the extrinsic fibers, we have the Sharpie's fiber. So that is present in the coronal half. Then is the cellular mixed and intrinsic, that is our apical half or the furcation area. So this is how you can remember all these fibers, where all these fibers are present. And also if you have your own story, you can comment in the comment section below. So guys, these fibers of the the type 1 collagen fibers. So these fibers, the intrinsic fibers of the cementum, are mostly made up of type 1 collagen fibers, and they are surrounded with the type 3 collagen fibers. Most of the cementum is formed by the type 1 collagen fibers, and also we have talked about the type 1 collagen fibers all halls are base में. That means all of the tissues, mostly all of the tissues are made up of type 1 collagen fibers. So also the fibers of the cementum are also made from type 1 collagen fiber. We have also studied the gingival fibers are also made from type 1 fibers, and also we have studied the PDL fibers are made from the type 1 fibers. Now guys, let's talk about the Cementum-enamel junction. So there can be of 3 types of Cementum-enamel junction. One is a kind of overlap writing. That means if this is enamel and the cementum is overlapping the enamel. So this is the cementum here, which is overlapping. So light yellow we are making. So this is overlapping the enamel. This is our overlap type of cemento-enamel junction. This is usually seen in 60% of the cases. Then guys, we have the another type, which is cementum just meets the enamel. So the junction is cementum just meets the enamel like this. So this is enamel. Then we have got the cementum which just meets the enamel. So this type of junction is what do we call the butt joint, which is the edge to edge. If you can see, this is the edge to edge. It is present in 30% of the cases. Then guys, we have the third type, which is when there is a gap present between the enamel and the cementum. So if you can see, there is a small gap which is present between the enamel and the cementum, and this is what do we call the gap junction, because the gap is present at the junction. So this is seen in 10% of the cases, right? So this was about the cemento-enamel junction. Now talking about the cemento-dentinal junction. So the cemento-dentinal junction in the primary teeth is kind of scalloped. So scalloped. But if we see in case of permanent teeth, it is smooth. So when we move the tooth apically, that means if we see at the apical foramen region where the cementum and dentine meets, it is very hard to distinguish the cementum and the dentine. And we have studied in endo also that if we are doing a root canal treatment, then the obturating material should be at the cemento-dentinal junction. So cemento-dentinal junction is usually 2 to 3 micrometers wide. So this is where the obturating material obturating material should end for the root canal treatment. And also, what are the effect of aging on the cementum? So cementum become irregular, and also there is a deposition at the apical area with age. And also we see that there is a deposition and the resorption, and this deposition and resorption creates the reversal lines. And we know that when the cementum is fused directly with the bone, when there is no PDL, this situation is what do we call the ankylosis. So also one more point which I would like to tell you is that the cementum is thicker on the distal surface of the teeth and it is thinner on the mesial surface. So now let's talk about the alveolar process. It is the portion of the maxilla and mandible which supports the teeth. So which is present at the socket lining, which is the alveoli of the, that means the bone which surrounds the teeth is what do we call the alveolar process, right? So this part of bone which surrounds the teeth is what do we call the alveolar process. Then it forms when the tooth erupts because it wants to give the attachment to the PDL. So the alveolar process, there is an external plate. So there is an external plate is what do we call the cortical bone. And one more thing I would like to tell you is that when we see this in case of a radiograph, this is known as the lamina dura, which is an important point for our exam view. So the external plate is the cortical plate and inner socket wall is made up of the compact bone, which is our alveolar bone proper. Alveolar bone proper. bone proper. So let's just demarcate it. The compact bone, which is the inside, and the outside we have is the cortical bone. And within this alveolar bone, if you take a histological cross section, you will find that there are some holes which are present. So how do we make these holes? Let's make it from the gray color maybe. Yes. So there are holes. Okay, this is not visible actually. But these holes are present in the alveolar bone proper, and these holes, they contains the neurovascular bundle. So there is basically a link from which the nerves passes to the periodontal ligament. So this is what do we call the cancellous bone. The cancellous bone. So the cancellous bone between the two compact layer act as the supporting alveolar bone. Also, in addition to that, the bones of the jaw, which includes the basal bone, which is the portion of the jaw which is located apically, but it is not related to the teeth. So the interdental septum, the bone which is present between the two teeth, if you see here, the interdental septum consists of the cancellous bone, supporting bone which is enclosed within the compact bone. So we see that the interdental bone is our cancellous bone. So this is the interdental bone, interdental septum. And we have got the organic component and the inorganic component of the bone, right? So let's write the organic component and the inorganic component. All these things we are going to talk about, not in here, in the DADH, right? So the organic matter of the bone is mainly made up of calcium and phosphorus. I'm sorry, this is under the organic we have written. So basically the inorganic matter is the calcium and the phosphorus. And the inorganic matter of the bone is collagen fibers, guys, which is type 1 collagen fiber. 90% of the time it is type 1 collagen fibers. Also we see there are non-collagenous protein like osteocalcin, osteonectin, bone morphogenetic protein. So all these proteins, osteopontin, bone sialoproteins, these are the co-adhesion proteins that are important for the adhesion of both the cells of the bone, the osteoclast as well as the osteoblast. So we also see, guys, one more thing, important point is the fenistration and dehiscence, which we are going to talk about here. Fenistration and dehiscence we are going to talk about in the surgical perio also. So the fenistration and the dehiscence, because these are the component of the bone. So if you see any isolated area which is present in the root, I mean denuded portion of the root, see, fenistration and dehiscence. D, remember, door, right? So that means a door is created. Fenistration means a window. So how do we describe it? Suppose this is the tooth, right? And somewhere here there is just a window of exposure, right? So this is we call the fenistration. This is what do we call the fenistration. And dehiscence is directly there is a door. That means a defect of the bone. So like this, all the surface are open. So this is the door, which is the dehiscence. So if the isolated areas in the root, in the denuded portion of the root is present, and the root surface is only covered with the periosteum and the gingiva, so that is what do we call the fenistration. That means the marginal bone is intact. Important point, a marginal bone here in case of fenistration is intact. But if we see the denuded areas, if they are extending into the marginal bone, that means extended. then we call the situation a dehiscence. So we see 20% of the cases, the fenistration and the dehiscence are more commonly we see these on the facial surfaces. So on the facial aspect of the teeth, and mostly in the anterior region we see compared to the posterior region. Now guys, talking about the last topic of today's lecture is the aging. So guys, aging, we are going to talk about 8 changes in the periodontium. So we have got the gingiva. In the gingiva we have the epithelium and the connective tissue. So we'll be talking about both of them. So 8 changes in the gingival epithelium. The width of the attached gingiva, it increases with the age. Rest of the things I'm going to tell you decreases with the age. That means stippling, we can say, decreases with the age. Then the keratinization of the epithelium, that also decreases with the age. All these points we have already talked about in the gingiva itself. Then the epithelium thickness also decreases with the age. That means the loss of the thinning of the epithelium. So talking about the connective tissue, only important points we'll be covering. So talking about the connective tissue, let's talk about what increases. So the strength of the collagen. Because the collagen number is decreased, so for that the strength is increased. So strength of the collagen. The denaturing temperature of the collagen, we know that collagen is a protein. So every protein has got the denaturing temperature, the temperature at which the protein disintegrates. So denaturing temperature of collagen also increases. Now at higher temperature with the age, collagen denatures. Also the conversion of soluble to insoluble collagen. Insoluble collagen also increases with the age. But the collagen synthesis decreases. So we are going to focus only on the increased part. So collagen synthesis decreased with the age. So the most important point here we have are the increased one. So width of attached gingiva increases, strength of collagen increases, denaturing temperature of collagen increases, and conversion of soluble to insoluble collagen also increases. Rest of the thing are going to decrease. Now talking about the age related changes in the periodontal ligament. So let's talk about the increase first. So we have talked about in the PDL also, the amount of elastic fibers. I could have written just the elastic fibers, but that's okay. The amount of elastic fibers increases, rest of the thing are going to decrease. For example, the number of fibroblasts decreases. For example, the connective tissue cells decreases, organic matrix decreases, rest of the thing are going to decrease. Only one thing in the PDL which we have to remember is the elastic fiber. So the amount of elastic fiber increases. Oxygen consumption decreases. Rest of the thing will decrease. So one thing which we have to remember in the PDL is amount of elastic fiber increases. Next, talking about the age related changes in the cementum. So the point which we have to remember is the width of the cementum. So we can write the cemental width. So width of the cementum increases with the age, and the permeability which decreases. So we are going to remember only increase point, right? So in the cementum we have to remember the cemental width, the width of the cementum increases. And bone, we know that with the bone there is a resorption which happens. So there is sclerotic changes increasing, resorption increasing, atrophy increasing, healing capacity is also delayed with the age. And we know some dental teeth related changes with the age, that is the wearing of the tooth surface. So we see that there is a adhesion, that means wearing of the tooth surface also is related to age. Adhesion, proximal wear also we see. So these are some age related changes. So this video we have covered the periodontal ligament, cementum, bone, and some age related changes. So guys, I hope that you have enjoyed the video. So if you have enjoyed the video, then give it a thumbs up. Also, you can comment in the comment section below. And you can now support on Paytm as well as on PayPal to make free videos like this for you and to get free notes which are available on our website www.x2.com, or you can just click on the link provided in the description box below. So guys, keep reading, keep learning, stay motivated. I will see you soon in the next video.